Assalamu alaikum. The short clinical day. First scenario, Mr. Ali present with short of breath. Please examine his cardiovascular system. Dr. Ayula, you can start now. You have 6 minutes.
Right.
Yeah.
Hello.
Good.
Hi. My name is Dr. Ayola. I'm Dr. Zie. May I confirm you are Mr. Ali?
Yes.
All right. And thank you for allowing me to examine you, okay?
Yes.
Okay. I'll be examining your chest and also some other parts of your body. It should not be painful, but if you feel any pain, please do let me know and I will stop. Is that okay?
Yes. Okay.
So I would. Are you okay to take your bed up a bit? So I'll put the bed at 45-degree head up, and then I'll go to the feet of the bed. I will examine. I will observe. Okay. Check the breathing pattern of the patient. Okay, and then I'll move closer. Check his finger, his hand. Okay, for any clubbing in the hands. Check for any muscle wasting. Then are you able to cock your hand for me, please? Can you cock your hand for me, please? All right.
Yes. Yes. There's no
Okay.
clubbing.
Okay.
No
all
muscle
right.
wasting.
Okay. All right. So I go to the pulse. I'll feel the pulse. How is the pulse like?
The voice is not clear. What?
I'm checking the pulse.
Yes. Pulse. There's slow raising, weak pulse.
Okay, weak pulse. Okay, I'm checking for. I'm checking both pulse delay, any irradial delay.
Yes. There's no regular. There's regular.
Okay,
There's
is it regular? Okay, all right. So I'm checking for collapsing pulse.
No collapsing pulse.
No collapsing pulse. All right. Thank you. And then I would want to check the blood pressure at this point.
Blood pressure 100/60.
100/60. Thank you. Okay, I'll check the highs. Can you put on your high lips for me? Okay, open your mouth for me. Let me have a look at your mouth. Any cyanosis?
There's no cyanosis.
No cyanosis. Okay. Can you face the other side? Turn your face to your left. I'm checking for JVP, elevated JVP.
GVP is not raised.
Is JVP not raised? So have you got any pain in your tummy?
There's no pain.
There's no pain. Okay, so I'm pressing your tummy right now to check for elevated JVP.
GVP still is not raised.
JVP, don't risk. Okay, thank you. So at this point, I'm going to examine your chest. Your chest, okay? So have you got any pain anywhere in your chest?
There's no pain.
There's no pain. Okay. So I'm checking for the apex beats.
Apex beat in place.
What intercostal space? Do you know? Okay. This space. Okay. Is it even?
Yes.
Okay, even. Okay, I'm checking for trio in the 4 cardiovascular region. And in the 4 valvular area.
Is what?
For trios. No trios. Okay, thank you. So I'm checking for. I want you to listen to the. I'm checking for the parasternal Eve.
No heave.
Eve. No Eve.
No heave.
No Eve. Okay, thank you. So I want to examine the breath sound, the heart sound. Sorry. I'm examining the heart sound with the diaphragm. What's the heart sound like?
Yes, the heart sound is S1 is edible.
S1 edible. S2. I'm checking on the apex beak first. Any murmur?
Any murmur? Yes, there's murmur. The apex.
Is that what?
It's systolic murmur.
Systolic murmur. I'm trying to time it with the carotid pulse.
There's systolic.
I'm timing it with the sector. Okay, systolic murmur. Okay. So can you breathe in and out, please? Can you breathe in and out? Hold your breath, please. Hold your breath on the out, on breathing out. Okay.
Increase when expiration.
Okay, by expiration. Can you turn to the left-hand side, please? I'm checking if it's radiates to the axilla.
There's no radiated axilla.
Okay, so I'm checking at the tricuspid area as well. Any more in the tricuspid area?
There's no murmur for the tricuspid area.
Okay, so I'm checking also with the bell of my diaphragm. So I'm also checking at the aortic area. Any more in the aortic area?
Aortic area, yes, there's murmur في aortic area.
You said what?
There's murmur in aortic area.
There is more.
Mm-hmm.
Okay, so I'm timing this with the carotid pulse.
Yes, radiated to carotid.
Okay, radiated with carotid pulse. Okay, does it come earlier with S1 or S2?
There's normal S1 and S2.
Okay, all right. So pulmonary area as well. Any more in the pulmonary area? Okay.
There's no murmur pulmonary area.
Can you sit up, please? Can you sit up?
Mm-hmm.
Thank
1
you.
minute left.
Okay, can you breathe and have? Can you lean forward? I'm checking the aortic area. Can you breathe in and
Mm-hmm.
out? Hold your breath in the expiration.
Yes, there's no murmur.
Okay. There is no. I mean, I'm checking it if it gets loud, worsen with expiration. On a sitting position. Okay. Thank you. So can you sit up? So I'm going to the back of. I'm going to your back now. Do you have any pain in your back?
There's
Okay.
no crepitation back.
So I'm checking for the basal crepitation. Any basal crepitation?
There's no basal crepitation.
So I'm going to your legs now, and I'm checking for any PD edema.
There's no bedding edema.
No PD edema. Okay. Is there any scar on the chest?
No scar.
No scar on the chest. Okay. Get what else up?
Okay, time is
Okay,
up.
thank you for allowing me to examine you. The examination I've come to an end. You can wear your clothes. Thank you.
Perfect. Yeah, good closure. Okay. Dr. Rasha, your questions.
Okay, presenting best your hair finding couple.
Okay. This young man that I've examined, I'm suspecting this patient might have I'm suspecting that he has an aortic stenosis. And because I'm thinking in this line because he has a systolic murmur that is louded in most, that is heard in the aortic area and also in the mitral area as well, and it radiates to the carotid. Apart from this, he also had a low volume pulse. As well. And I'm thinking that it might be a severe one because the second heart sound was not heard. There is no evidence of suggestions of heart failure, and there's no evidence of infective endocarditis. Okay, so I'm thinking it could be an severe aortic stenosis.
Okay. But regarding the how can differentiation is isolated aortic stenosis or mixed with the mitral regurg?
Is that what?
Because there's systolic murmur to the mitral area.
Okay.
Why
Yes,
not say this the murmur is not mixed lesion?
Yeah, I'm thinking of that, but because when I examine the possibility, but when I examine it, the pulse was not, this murmur was not radiating to the axillary area. It was not radiating to the arterial area, so this would not make me think of that. But it's this possibility that there might be a mixed possibility of that.
Yes. Okay. What are differential diagnoses of ejection systolic murmur?
Differential diagnosis could be hypertrophic cardiomyopathy. It could also be it could also be long-standing hypertension or an innocent murmur, especially in pregnancy, and also ventricular septal defect can also be a differential. Also, aortic sclerosis.
Okay. What against there's no a VSD, no ventricular septal defect?
Evidence of ventricular defect. I would have expected that the murmur would have been loudest in the left parasternal area, which in this patient, which in this patient, it is in this gentleman, it is louded in the carotid area, and also sometimes ventricular septal defect can also be associated with tricuspid regurgitation, as well as some evidence of pulmonary hypertension.
Okay. What are the severity marker of the aortic stenosis?
The severity marker of aortic stenosis could include slow rising pulse, which is evidence in this gentleman. slow the pressure, sorry, narrow pulse pressure, also silent S2, and also the murmur could also become silent in severe aortic stenosis.
What investigation you wanted to do?
To investigate this young man, I want to do a transthoracic echo to assess for the aortic area diameter, which will further judge in my management plan. And I want to do a transthoracic echo who will help further in the management of this patient. And then okay, I also want to do a chest X-ray for him, and also want to do electrocardiography and electrocardiogram, sorry. And yeah, basically that's what I want to, yeah.
Okay. How to treat?
To treat this patient, the treatment is depending on whether this patient is symptomatic or not, or also on the severity of the disease. If it's asymptomatic, and for the particular patient that has a severe, I'm taking have a severe aortic stenosis, depending on what the echo findings is, if it's less than, if the aortic area is less than 1.0 centimeter, or the aortic venous velocity is greater than 4 millimeters per second, I want to manage the patient with aortic valve replacement, depending on the clinical status of this patient, if he can take it, if he can tolerate it. If not, I will consider a trans aortic catheter implantation for him. I also want to do a coronary angiography to see if a coronary angiography, if there's any coronary artery disease, to afford combination with coronary artery bypass graft as well. Then if the patient is asymptomatic, I want to keep monitoring the patient with routine echocardiography and intervene when they become severe, or there is clinical, there is symptoms of heart failure. But if there's symptoms of heart failure, I also want to comment on anti-failure regimens such as diuretics, beta blockers, and beta blockers, and then ACE inhibitors.
Yes, for aortic stenosis. Okay. What are criteria for aortic sclerosis?
Okay, for aortic sclerosis, you said, it also presents with aortic adjacent to systolic murmur, but it does not radiate to the carotid area. Okay, that's what I can remember for now.
Okay. Time up?
Yeah,
Thank you.
Yeah, almost up. 2 minutes extra. I want to ask Dr. Ayula, you said diuretics. When exactly you can
Yes.
give diuretics in this scenario?
If there is heart failure, evidence of heart failure.
Yeah, only this situation you can give.
But
Otherwise,
I think in aortic
it's
stenosis,
contraindication.
yes, and also ACE inhibitor contraindication.
Yes,
Yeah.
please have. Yes, sorry, it was a error in me. Yeah, honey.
Yeah, but if there is heart failure, yeah, this is the only situation in the acute heart failure you can give. Otherwise, it's contraindicated. Okay, vasodilator or diuretics or nitrate, all of them are contraindicated in case of aortic stenosis. Clear? Yeah, perfect, Dr. Ayula. Let's start the comment, Dr. Rasha. And
Yes,
Dr. Ayula, please prepare the case for Dr. Rasha.
yes, perfect. But there's some delay on examination. Take more time to talk the patient, to take permission of the patient, ask about blood pressure. I think there's some 1 minute in introduction. Because take more time for examination, because I think in the examination you need to concentrate it about the murmur and concentrate it about that. But all of overall is done, is good.
Okay. Anything related to the case? Any missing?
Regarding
Any missing finding?
just only missing to comment about the third and fourth heart sound, because the fourth heart sound the sign of the severity. Um, just only like this added sound for added sound.
Okay. Any other comment?
No.
Okay, thank you, Dr. Rasha, for preparing the case.
Welcome.
Yeah, since Dr. Ayula was not prepared for cardiovascular, I think she finished on
Yes,
time. Yeah,
she's good.
so
Yes.
yeah, she did great, and she finished almost at the time. She finished at 6 minutes exactly. She thanked the patient. She asked him, or she covered him, which is very important point at the end. As introduction, yes, you have to prepare yourself to wash your hand and introduce yourself, confirm the data of the patient, his name and his age, and the agenda. I will examine you. Please, if you have any pain, let me know, or discomfort, or if my hand is cold, please let me know. Okay, just try to do all these steps before starting any examination through all the stations. Okay, and she did that. Even she took some seconds, but it's okay. Better than forgetting that or missing that. Okay, let's go to the steps. She examined the peripheral signs, which is important in this scenario. What do you think, Dr. Ayula, you missed while presenting?
البلس.
Yeah,
Yes, البلس.
I think the pulse is important to be mentioned. The irregularity, the pulse volume. Here you cannot examine for collapsibility. Why? Because it's already weak pulse. So you cannot say I want to examine the collapsible. Is it collapsible or no? Because it's very weak pulse. Okay. Let's go to the peripheral signs of infective endocarditis. At the end of the presentation, you have to say, I couldn't appreciate the negative signs. I think she mentioned the heart failure, right? She mentioned
Yes.
the
Pulmonary
but
hypertension.
pulmonary hypertension, but the infective endocarditis signs, did you mention, Dr. Ayula? So the heart failure, you have to
Yes, I did. I was muted. Yes.
perfect. Okay. So you have to say these four or three negative finding if you didn't appreciate. If you appreciate, you will, of course, starting by presenting the positive finding. But if you didn't appreciate them, you will say at the end, I couldn't appreciate signs of heart failure. I couldn't appreciate signs of infective endocarditis. I couldn't appreciate signs of pulmonary hypertension. Okay. So my findings suggestive of aortic stenosis plus mitral regurgitation, for example. It's difficult to pick up both pathology, by the way, but if you can give the most symptomatic one. In this scenario, I think aortic stenosis is more predominant than the mitral regurgitation. However, there is murmur over the mitral area or over the apex, which is radiated to the apex or to the axilla, sorry. So there is mitral regurgitation. But the most important to be mentioned, aortic stenosis murmur radiated to the carotid. Back to the peripheral signs. So if you finish the peripheral signs at the hand, you will ask the patient if he, sorry, you ask the patient if he has any pain. If you want to do the collapsibility, but in this scenario you will not do because there is weak pulse. Okay. Always try to compare both sides arterial pulsation, radial pulsation, and offer to examine for radiofemoral or radioradial delay. Okay. After finish the collapsibility or the collapsible pulse, you will examine the face for the eye, any jaundice or pallor, the mouth for dental hygiene. It's important. What do you think the importance, Dr. Ayula, in this scenario? You are unmute,
I'm
Dr.
thinking of perhaps infective endocarditis.
Perfect. So you have to open his mouth for cyanosis first and for dental hygiene. If he has any poor dental hygiene, you can comment on it at the end because this patient will be high risk of infective endocarditis. Okay. Sorry, there is echo. Back to the examination, the raise GVP as Dr. Ayola did, and don't forget to examine it while in 45 degree. Okay. Press over the abdomen as Dr. Ayola did. Any tummy pain, and press and observe for any raised GVP. Then now you examine for the chest, inspection, palpation, but no percussion, of course, then auscultation. The inspection for any scar. Please take care and pay attention to the hairy men. Sometimes the scar could be covered under the hair. So please focus on the area of midsternum or midsternotomy scar. Sometimes with good hands and good surgery, the scar could be covered under the hair. So please try to discover and focus on this midsternotomy scar. This is for the inspection. Now the time for the apex beat. You can inspect the apex beat. Is it in axillary or mid-clavicular, displaced or whatever? Then you can check and examine by palpation the apex beat. Is it displaced or no? And try to pick up the characteristic finding or the criteria of the apex. Is it heaving? Is in this scenario, it would be heaving pulse or heaving apex for aortic stenosis. Okay. Then the next step will be the auscultation. You will auscultate for murmur starting from the apex, mitral area, start by the diaphragm for mitral regurg and the radiation to the axilla. If there is no, you will examine by the bell for mitral stenosis. And of course, you have to do the timing with the carotid pulse and ask the patient to take breath in and out and hold. For the mitral area and aortic, the patient will be holding breath after expiration and auscultate after that. If you are examining the pulmonary and tricuspid, ask the patient to breathe in and hold. I hope it's clear, all the steps till now. Then the parasternal left area first, and the right parasternal, then pulmonary area, and the aortic area first and second. But in the sitting position, you will start examining the first aortic area. While leaning forward for aortic regurg, you will examine the third left intercostal space for the second aortic area. Don't forget the parasternal heave palpation after examining or after palpation of the apex, plus the loud B2 while examining the pulmonary area. Mitral stenosis commonly will be complicated by pulmonary hypertension. Even in this scenario, it might be complicated by pulmonary hypertension. Okay. After that, you examine the back for any bibasal crackles, for heart failure, sacral edema. Before examining for the sacral edema, you ask the patient if he has pain, and end your examination by examining the legs. And here is very important. Don't miss the scars in the legs. Sometimes the patient he has post PCI or cabbage, and he has donation or he has harvesting venous graft from his legs. So try to pick up this finding while examining the legs. Even if the patient is wearing socks, you have to expose, or if he's or she or he is wearing bands, ask the examiner and offer to examine his legs or her legs up to the knees. And of course, the pedal pulse and pedal edema. This in summary how to do examination of cardiovascular. I think the case here is straightforward for aortic stenosis. There is mitral regurg. The finding already mentioned by Dr. Ayola. The investigation, please, Dr. Ayola, don't forget the specific investigation. In this scenario will be ECG and echo, cardiac enzymes, troponin, BMB. This is specific. General investigation, you have to mention all the general basic workup: CBC, coagulation profile, liver function, kidney function. What do you think the importance of CBC in this scenario, Dr. Ayula? It's an important question, by the way. Coagulation profile, important. Two cases, they have different question and different answer. For example, in replaced valve, he will ask, you have to do the coagulation profile. Why?
Because of the mechanical hemolysis.
Exactly. Not only hemolysis.
And because it will be on anticoagulant.
Perfect. Exactly. This is the point. So coagulation profile, you have to specify, or you have to mention the coagulation profile in any cardiovascular patient, either native valve or even replaced valve. Why? In the native valve, I will mention now, but we start with the replaced. So the patient would be on anticoagulant and he should be following with the INR clinic for the target INR. In the native valve, what do you think the importance of coagulation profile? Dr. Ayula?
Yeah, I'm with you. I'm just trying to reasoning.
Okay, it's not,
I'm not sure.
Yeah, in indirect way, you would have some hemolysis workup. So the importance of the CBC would be most important, not coagulation. Okay, so the CBC will show you if there is hemolysis. So you might have anemia, and they will ask you what the type of anemia. Okay, be ready for this question. What the possible type of anemia in? Yeah, tell me.
Maybe anemia of chronic disease.
Or
hemolytic anemia because of the stenosis.
So it would be normal or hypochromic.
Okay.
What type of anemia?
It would be pneumochromic.
Perfect. So normochromic, yes. Okay. So it would be normocytic normochromic anemia with the hemolysis. Okay. Yeah. So these questions would be important to know and to be ready. You might be asked about this specific investigation, as I mentioned before entering the neuro and cardiac station. Please try to remember, and because no paper or no scenario in the cardio and nervous system station, no scenario. You will be sitting 5 minutes, not doing anything. So what you have to do in this 5 minutes, try to write in your paper how do you present the case and what's the possible investigation, how to present the investigation. As I always prefer to say, the general investigation, specific investigation, bedside tests, imaging, and invasive tests. Okay, there is 5 minutes before the cardiovascular and nervous system station. If you are not mentally prepared, you will have mental block inside. Okay, so please, in your paper, try to summarize or to put a scheme how to answer the questions and to refresh your mind how to investigate every patient, either nervous system or cardiovascular. Put the scheme outside in your paper. So the general, specific, we already mentioned the specific. Please memorize it by heart. The specific investigation in any cardiovascular station, you have to put ECG, or ECG might be bedside. So you have to say, I would do the BMB and troponin, cardiac enzyme troponin. Okay, these are the specific cardiac investigation, right, Dr. Ayula? What are the bedside tests you have to do?
ECG.
Perfect.
You have to do pulse oximetry.
Okay.
And bedside echocardiogram.
Perfect. Yes, perfect. Yes, what you mentioned is perfect. This is what you have to mention in any specific or bedside test in any cardiovascular station. Okay, don't forget the specific investigation, not only BMB and the cardiac enzyme troponin. If you suspect infective endocarditis, you have to send for what investigation you can do for infective endocarditis, Dr. Ayula?
You would do blood culture.
Perfect. So you can say this is one of the specific investigation if I suspect infective endocarditis. By the way, any patient with replaced valve, you have to put infective endocarditis one of your differential, isn't?
Yeah.
Yeah. Any stenotic valve, any diseased valve, you have to suspect infective endocarditis. Okay.
Mm.
So be ready to mention specific investigation for infective endocarditis. One of the important questions the examiner asks in any cardiovascular station, what are the DUC criteria? What are the criteria of infective endocarditis? Specifically, when you say, I couldn't appreciate signs of infective endocarditis, he will tell you, doctor, give me the names or the possible manifestation of infective endocarditis. Can you enumerate them?
Yeah, Duke's criteria,
Okay,
modified Duke's, and it's major and minor.
okay,
Okay, the major is when you are able to culture the typical organism in two different culture.
okay.
I think 12 hours. Oh, no, I think they removed
Yeah,
the
12
1
hour
hours
apart.
apart.
Okay,
Then echo
perfect.
findings like abscess, vegetation.
Perfect.
That's the two major. Then the minor
Okay,
criteria: fever greater than 38 degrees
okay,
Celsius. Then vasculitic events.
perfect,
Then embolic phenomenon.
perfect.
Then
He will ask you specifically what vasculitic and embolic phenomena you know.
okay, for the vasculitic phenomenon, glomerulonephritis,
Okay,
and the embolic phenomenon, Janeway lesion, oslar nodules, root spots,
mm-hmm.
and the echo findings that are not typical of infective endocarditis. Then the atypical organism, if you see it's atypical organism, well, those are
Okay,
important.
that's
Then
enough. Splinter hemorrhage, Janeway lesion, oscar nodes, you have to mention them.
okay, yeah, splinter
And
hemorrhage.
the vasculitic for glomerulonephritis. It's important to remember all these findings. Okay, what the possible hemolysis can happen with aortic stenosis?
What?
The hemolysis. Is there
Like,
possibility to have hemolysis with aortic stenosis? What is called?
yes, it's possible to have aortic stenosis. I can't remember the name now, but I know it's related
Yeah,
with gastric dysplasia.
exactly. Yeah.
Yeah.
What's called this syndrome?
I can't remember the name of the syndrome now.
Heidi syndrome.
Yeah,
Yeah,
Heidi
eye
syndrome.
disease, yes.
Yeah, Heidi syndrome. Yes, perfect.
Yes. Thank you.
Yeah. I think, yeah, the management plan, of course, it depends on the disease. And whenever you have symptomatic patient, what the first option you have to mention?
To relieve the symptomatic management of either if it's heart failure, you manage the heart failure.
Okay, if there is heart failure, you manage the heart failure. What
Yes.
after? What next?
Then surgical management.
Surgical yeah, exactly. This is the point. So the surgical management, of course, this is the definite management for any symptomatic valvular disease. In this case, what is the options?
We can do aortic valve replacement,
Perfect.
which you could have done a coronary angiography before you go ahead, should include a
Perfect. You have
CABG
to
be
remember,
needed.
yes, I like when you mention that. So whenever you are going to replace the aortic stenosis or aortic replacement, you have to do coronary artery before that. Why? There is possibility to have coronary artery disease, and in the same time you can do CABG, right? So you will do open heart, changing the valve, along with vessel change or vessel replacement, right?
Mm.
Okay. Uh, next, what are the echo finding or criteria and indication for of surgery?
Okay, the criteria for surgeries include severe aortic stenosis that is indicated by
Sorry,
aortic
you are
valve.
muted. We cannot hear you, doctor.
Okay, sorry. Let me
Yes. Yeah. Repeat it, please.
Okay, I said severe aortic stenosis as indicated by aortic valve area that is less than 1.0 centimeter, or aortic arteriovenous velocity that is greater than
Perfect.
4 millimeter per second.
No need to mention numbers, by the way. So you can
Okay.
say tight valve, okay, tight aortic or narrow or tight, very tight aortic surface area.
Mhm.
Or you can say, as you said, there is velocity, change of the velocity or gradient between the
Okay.
area before and after the valve. No need to mention how much the numbers, okay?
Okay.
And so clinically, how do you say this patient is having symptomatic or severe aortic stenosis?
When there's symptom of heart failure,
Yeah. What
then
other symptoms you know?
of pedal edema, shortness of breath, autopnea.
Okay,
Then
this all heart failure. What other complication you know?
what was actually infective endocarditis.
Okay.
What else? Aortic stenosis, heart failure, endocarditis.
How aortic stenosis could be presented?
Okay, shortness of breath,
This is
dyspnea,
as okay as heart
dyspnea.
failure. No. I am talking about other manifestation apart from the cardiac manifestation.
Apart from what?
Cardiac manifestation or heart failure manifestation.
They could manifest with angina.
Perfect. This is what I need from you. The
Okay.
angina or heart failure. And the third is, could he present with syncope?
Yeah, syncope sad, yeah.
Yeah, you have to mention it. It's very important. So it's one of the indication even. If the patient is having syncope or heart failure or angina, this patient is candidate for replacement and surgery. Okay. Yeah, the investigation, not in this case, as image you already mentioned, coronary angio. Do you know what the possible invasive intervention or invasive investigation you can do in any cardiovascular station, but not specific for this case?
Uh, Cardiac catheterization.
Yes, perfect. This is what I need. In what case you want to do it?
If there is pulmonary hypertension.
Perfect. Amazing. Really, mashallah. You did everything. You mentioned everything I need to the target. So whenever you have possibility to have pulmonary hypertension as a complication to your original disease, you have to specify or to say one of the investigation. Even the examiner might ask you what the test you can do as invasive to investigate this patient for his pulmonary hypertension. So you have to say right side catheterization, heart catheterization, okay? I think this is enough for the first case. Anyone has doubt or comment? Please. Dr. Ayula first, you want to comment or to say something? Any missing or suggestion, any question, any inquiry?
No.
Dr. Rasha?
Doctor, can I ask?
Sorry?
Can
Hello?
I ask?
Yeah, Dr. Huda, yes, go ahead.
For the CBC for aortic stenosis,
Yes.
I think this patient have iron deficiency anemia because that's bleeding in the intestine, yeah, not normocytic.
Yeah, I think we mentioned normocytic for the replaced valve, not for the Heidi syndrome. Heidi syndrome, yes, there is possibility to have angiodysplasia, so the patient will have iron deficiency anemia. Yes, you're right. You're correct. But when we mention the question was about the replaced valve. What's the possible manifestation in the CBC in replaced valve? So it would be normocytic, normochromic anemia. But in the Heidi syndrome, since he has bleeding angiodysplasia and he has, of course, bleeding or blood loss, so the possibility here will be changed to microcytic hypochromic anemia. You're right.
Okay, thank you.
Thank you, Dr. Huda, for the attention. Any other point you want to raise? Okay. Any suggestion from others? Any doubts? Dr. Rasha, you want to ask? You want to add?
No.
Yes, okay. Dr. Ihda, yes, I think she's asking about the point of surgical treatment for CABG with aortic stenosis. Whenever you have patient with aortic stenosis, before proceeding for valve replacement, you have to do the coronary angio. Why? Because at the same time, you might change or you might do harvesting and do the artery replacement or the what's called coronary angio. Yeah, coronary angio. You change the coronaries. So you can do it in the same session or in the same surgery. So you will not do it in two steps. You will open his chest and you will do the valve replacement for aorta, and in the same time for you can do the artery replacement, coronary arteries, I mean. Okay, most of them they have angina, right? We mentioned already one of the presentation might be angina, so it might be affected or he has coronary artery disease, so you can do the same surgery while opening his chest, first for the valve replacement and the artery replacement. Clear? Okay. Thank you, Dr. Ida. Any other question? Remember this point, by the way, it's common question. Whenever you have aortic stenosis, you have to do coronary angiography. So you will draw the arteries. If there is any stenosis, if there is any clotting or any manifestation of coronary artery disease, the patient would undergo the same surgery while opening his heart or while opening his chest. Okay? Dr. Ayula, you prepare another case for Dr. Rasha?
Yes, please.
Yeah, let's move on. Dr. Rasha, your case, Mr.
Okay.
James referred to his GP with a new murmur. Please examine his cardiovascular. The age only, Dr. Ayula, please, you can add.
Oh, yeah.
By the way, whenever you have
If-
young patients with ejection systolic murmur,
Mm.
you can say how come one of the differential. Whenever you have elderly patient with ejection systolic murmur, you have to give differential of aortic sclerosis. So according to the patient age, either to give HOCM as a differential or to give aortic sclerosis as a differential. Both of them are differential to each other, but the priority, for example, if you have elderly patients, so you will say aortic stenosis, aortic sclerosis, HOCM, but against that he's not young or he's elderly. On the other hand, if you have young patient, so you will tell the examiner aortic stenosis, HOCM, aortic sclerosis, but against that he's not elderly or he's young. Okay.
بس إضافة
Yes.
بسيطة، فينا نضيف البايكاسبيد.
Yes,
تمام،
sure.
يعني إيه
Yeah.
هو كان مثلا لو young, if he is young, هو كان bicuspid, especially that bicuspid can present with stenosis or regurg, فit is a good differential for both types of murmur, whether
Yes.
diastolic or systolic, and it can be congenital, so present early, and it can be there early but was past undiagnosed, which led to early sclerosis لأنه the valve is unhealthy, so it can lead to early aortic sclerosis. In the middle between HOCM and aortic sclerosis or aortic stenosis in elderly, you can really put bicuspid like this. You will have 3 differential. Usually they don't ask for more than this. If they ask what else, what we can put for ejection systolic murmur.
Pulmonary stenosis, you mean?
Pulmonary stenosis is very rare. Usually we put MR, صح؟ لأنه more common. I agree, PS is ejection. But you can put MR, more common, PS agree, or VST. Those also can lead to ejection. Not ejection, let's say systolic.
Yeah, systolic murmur, exactly.
Systolic murmur, yes, not
Yeah.
ejection. لأنه ejection صح كلامك, you are right. It will be pulmonary stenosis top, لأنه it will give ejection systolic murmur.
Yeah.
But in general, systolic murmur can be these differential. Top, as Dr. Bassem said, HOCM. aortic stenosis, we can add bicuspid. Usually if he asks you, where do we see bicuspid?
Yeah, good question. I think Dr.
can-
Ayula can answer this question.
In which scenarios?
Dr. Ayula, when
In
you
which
can
sense do we have what? Bicuspid what?
bicuspid valve,
Bicuspid aortic
aortic,
valve.
yeah.
In which
In what?
scenarios do we usually have this anomaly or this congenital anomaly?
Okay, perhaps in
Yeah, you can do it.
Mathans. No.
Not-
Mama fans will be
not-
more of incompetent. Yeah.
Yeah,
Incompetence and aortic dilatation more.
Mm.
not bicuspid.
Not
Bicuspid, another
bicuspid,
another syndrome. Yes.
Start with T.
Turner syndrome.
Mhm.
Turner, yes, you are right.
Yes.
And you can say that the good answer, it can be isolated congenital anomaly, it can be in association with co-arcutation,
It's one of the
or
health.
in association with Turner. In Turner syndrome, you can have both co-arcutation plus bicuspid or any one of them. And sometimes the patient is not Turner, but he have co-arcutation of aorta. Usually with co-arcutation of aorta, we get bicuspid, and sometimes bicuspid can be isolated congenital anomaly. Tamam, so isolated or in association with co-arcutation or in association with Turner. These are usually the scenarios where you get a bicuspid aortic valve. I don't لا بس هدول كنت بدي أقول نونان، تذكرت نونان رايت سايد ماله بالليفت صح؟
Pulmonary. Yes.
ايه
Pulmonary.
pulmonary وترايكاسبيد، فبس هدول تقريبا شو ما كنا نسيان، بس أنا بتذكر هدول اللي على
Down
راسي.
down syndrome, Dr. Hind.
ممكن صح، داون سيندروم في كل انواع الكونجنتال انومالي، بس these three يعني isolated or with co-arcutation Turner. If you ask what else you can put بقى بقية الكروموزوم abnormality like Down syndrome. اوكي،
Yes. Thank you.
ان شاء الله تكون اضافة لطيفة ما كنت
Yes, of course. No, as usual, valuable, Dr. Hind. Thank you so much.
الله يسعدك يا رب.
Thank you. Okay. Dr. Rasha, you ready? We can start?
Yes.
Yeah, here you go.
First of all, I wash my hand and read the instruction. I go to the patient, ask, I'm Dr. Al-Mahdi. I'm here to examine you. If you have any pain, please let me know. And then started from the general look of the patient and the general surrounding. And after that, go to the hand. If there's any clubbing, if there's any cyanosis, if there's any flapping tremor, and then check into the pulse, volume, rhythm, or synchronize.
The volume is bounding.
Mm-hmm.
Bounding pulse. 100 beats per minute, regular.
Okay, regular, and also ask the patient if there's any pain to check the collapsing pulse.
Collapsing pulse.
There's collapsing pulse?
Yes, please.
Okay, and after that, go to the head to check if there's any pallor, if there's any jaundice, if there's any pallor, if there's any jaundice. Examine to the mouth if there's any cyanosis, and then go to put the patient to the 45 degree and examine the JVP.
JVP elevated.
Uh-huh. Okay, ask the patient if there's any pain to do hepatojugular reflex.
No pain.
No pain, okay. And then go to the lower limb to check if there's any pitting edema, if there's any scar, peripheral pulse.
Pitting edema, no scar.
Okay, and then go to the chest examination, if there's any scar.
No scar.
Okay, and then put my hand into the fifth intercostal area to check the apex beat in place or not.
Apex beat displaced laterally.
Displace, okay. Displace the sex intercostal space.
Yeah.
Okay, and check the character of the apex.
Even.
And check if there's any thrill.
Trill in the aortic area.
Okay, and check if there's any palpable second heart sound.
Second heart sound, normal first and second heart sound. With the third heart sound.
Okay, and then do auscultation and then auscultate the apex. Put the patient in the diaphragm, and then yes, and put the stethoscope into the bells and ask the patient to turn to the left side.
No murmur.
No murmur. And after that, ask the patient to come back to examine the tricuspid area. examine the pulmonary area, auscultate the pulmonary area, auscultate the aortic area.
More in the aortic area, closer to H2.
There's murmur in aortic area. Okay, radiated للcarotid or not?
No, not radiated to the carotid.
Okay, and then ask the patient to sitting and patient leaning forward to examine the second aortic area.
Okay, Momo is louder when the patient leans forward.
Okay, ask the patient to take in deep breath and expiration and then hold.
Okay, louder on expiration.
Loud, okay. And then examine the chest if there's any basal crepitation.
Any what? Basal crepitation, yes, by
Basal,
basal crepitation.
Basal crepitation. And then ask the patient if there's any pain to check the sacral edema.
No sacral edema.
No sacral edema. Okay. Okay. I would like to complete my examination to check the vital sign and do urine for dipstick, and also examine the abdomen for examine the abdomen if there's any splenomegaly, and examine the abdomen for splenomegaly. Finish.
Okay.
Since you have 2 minutes left, what you mean to examine specifically in this scenario?
In this scenario,
Yeah.
other than cardiovascular?
Yeah, it's related to the original disease.
Yes, if patient, yes, I want to check the abdomen if there's any splenomegaly.
No, something else. What's your suggestion of this patient finding?
Yes, patient is presented. Yes, this the gentleman, comfortable into the bed, presented in the collapsing pulse, and there's no raised GVB, no beating edema. There's this diastolic murmur to the second aortic area, increased by expiration. There's no sign of heart failure. There's no stigma of infective endocarditis.
Perfect.
Uh-huh.
Still 1 minute left. So the finding suggestive of what?
Aortic regurg.
Perfect. What do you want to examine specifically as a manifestation of aortic regurg? What's called? Or what are called? Peripheral
Examine
sign.
if there's any, yes. Okay, examine if there's any peripheral sign.
Exactly. Go ahead. Examine one by one. Tell me what you want to examine, and Dr. Ayula will answer you. Okay.
Yes. The first of all, examine the nail. If there's any pulsation under the nail.
Okay, no problem.
Okay, and also ask the patient to open the mouth if there's any pulsation in uvula.
Yes, there is.
And there's also, I examine to the neck if there's any Corrigan sign.
Yes.
And also I want to auscultate the femoral if there's any systolic and diastolic murmur.
Perfect. Perfect, Dr. Rashad. Time is up and you did everything. What is the sign, what's called the sign in the femoral artery? What's called?
Postal shot sign?
Yeah, thank you.
I think والله مش متذكرة.
Yeah, perfect. Amazing. Dr. Ayula, you can start your examination.
Okay. So can you summarize this patient?
Yes, this is the gentleman, 65 years old, patient comfortable into the bed. There's no sign of respiratory distress. There's collapsing pulse, wide pulse pressure. There's an epic speed into the place. There's epic speed is displaced 6 intercostal space. There's S1 and S2 audible. There's no any S3 or S4. Their diastolic murmur to the aortic area increased by expiration. There's no sign of heart failure. There's no sign of pulmonary hypertension or beating edema. Most likely the feature suggested of, and there's peripheral sign of aortic regurg. Most probably this patient severe aortic regurg. I want to do echo to confirm my diagnosis.
Okay, thank you. So what do you think might be the other differentials?
Other differential of like mitral stenosis and tricuspid stenosis.
All right.
Uh-huh.
And you mentioned this patient man has aortic regurgitation. What do you think can be the cause in this man?
Regarding this man, aortic regurg, okay, there's cause acute aortic regurg or chronic aortic regurg. If the patient acute aortic regurg, maybe trauma, maybe coarctation of the aorta, maybe rheumatic fever, maybe chronic hypertension, and connective tissue disease, and other cause like Ehlers-Danlos Marfan syndrome.
Okay. And you mentioned this young man has collapsing pulse. What are the other causes of collapsing pulse?
Collapsing pulse, because there's difference between the systolic blood pressure and diastolic blood pressure.
Okay. I mean, what are the other causes of collapsing pulse?
What?
Other causes of collapsing pulse.
Other causes, yes. Other causes like beta ductus arteriosus, like anemia, like like anemia, like pregnancy, like beta ductus arteriosus. Okay.
All right, thank you. So could you tell me the evidence of severity in this young man? Did you pick any evidence of severity?
Yes, because the patient presented with the peripheral sign, that indication the patient with a severe aortic regurg. And also if the patient symptomatic, there's indication of severe aortic regurg. Yes.
Okay, so how will you investigate?
Apart from the basic investigation, CBC, LFT, inflammatory marker, renal function test, liver function test, I want to do ECG, chest X-ray. I want to do echo to confirm our diagnosis. And also I want to do CT aorta, or CT or MRI aortic, yes, to see CT or MRI for aorta.
Okay, so what will be your management plan in terms of treatment?
Okay, the pharmacological, non-pharmacological, patient education and counseling. Treated if the patient antibiotic, if there's indication. Treated the patient of if there's any antibiotic if there's any indication. Regarding the aortic regurg, treated the patient by ACE inhibitor. And if there's the patient symptomatic and there's indication to the echo, may be needed to the valve replacement.
Okay, thank you.
Welcome.
I don't know if you would like to say something.
Perfect. No, good question, by the way. And Dr. Rasha also answered well. What are the echo finding suggestive of surgery? Dr. Rasha.
The echo finding, ejection systole, ejection fraction less than 60. There is end systolic more than end systolic more than 50, end diastolic more than 70. There's aortic root dilatation more than 55.
Okay, let's correct the numbers and the values. Okay, so it's not end systolic, it's end diastolic. And ejection fraction. Yeah, and
Yes,
ejection fraction.
diastolic more than 70, diastolic on 70,
No.
with systolic 50.
The ejection fraction less than 50.
Yes, ejection, okay.
And the end diastolic volume, how much? Diameter, sorry, how much?
Diastole 70.
More than 50. Always remember the rule of 100. Okay, rule of 100. Ejection fraction less than 50. Sorry, in aortic regurg,
rejection
40.
fraction more than
40.
60.
Yeah. No. In this scenario, in the aortic regurg, the ejection fraction is supposed to be normal, 50, right? It would be less than 50.
I think supposed to be high. Ejection fraction support
No,
to be high
in mitral regurg, supposed to be high, not in aortic. If I'm not also mistaken, I'm not sure. Someone can correct. But remember 50 and 50. In ejection fraction less than 50 and in diastolic volume more than 50. So this is or these are indication for replacement. Okay, I think someone wrote it. End diastolic diameter equal more than 70. End systolic diameter equal or
لا
more
لا لا
than 50.
أرقامك أنت دكتور باسم اللي صح، عملوا أبديت.
آه.
أنا مشخته على القديم كان 70
Okay.
75.
Yeah, yeah.
الجديد تارك القديم عشان إذا حدا حط الأرقام القديمة نتذكر إنه هذا القديم. النيو
Mhm.
فاليوز الأورتيك روت لا استنى ليفت، بس أنت قلت كأنه diastolic، هي أنا مكتوبة عندي
Yes.
left ventricular and systolic is
End
more than
systolic.
50 والإجكشن fraction is less than 50.
Yes.
تمام،
50.
فهدول
Yeah.
الاثنين يلي مكتوبين عندي.
Okay.
والاورتيك روت دايلاتيشن more or equal to 50، مشان هيك قاعدة 50 تبعك مضبوطة 100%.
Okay. Good. Okay.
تمام. ejection ejection left ventricular systolic dysfunction اللي هي ejection fraction less than 50. وعندنا left ventricular end systolic volume more than 50. وعندنا كمان قلنا dilatation more or equal to 50.
Okay. Thank you.
في عنا كمان indication تانية بس ما بعرف إذا
Mhm.
لساتها applied اللي هي الوايت pulse pressure more than 100. لو طرحت السيستول من الدايستول و you find the difference is more than 100 this is a sign of severity. وانت بالعادة بيكون عندك ال value of the blood pressure you can ask the examiner, so this is something you can obtain during the exam. ال ECG changes on exercise tolerance test. وعندي كمان indication الكابج concomitant cabbage. هذا لو البيشنت كان asymptomatic. concomitant cabbage ejection fraction left ventricular end systole aortic root dilatation white pulse pressure exercise. مشان هيك مهم, that's why it is very important in the investigation to mention the exercise tolerance test, because it is used in risk stratifying the patient whether for a surgery or not. تمام. this is what I have. والباقي symptomatic. two important symptom, angina and heart failure for aortic regurg. تمام.
Yes. Okay. Thank you, Dr. Hind.
نعم.
Okay. Dr. Rasha, Dr. Ayula, comment first.
All right, well done. It was a good presentation. Just a few things here and there. I think when we are examining, especially when we are doing online, I don't know, I think personally, I prefer to say it the way I would say it to the patient. Initially, I was confused because it seems like you were teaching, sort of like that. So I think that when you tell me exactly the way you would tell the patient, it's that's what I think anyways. And I think it would stick better than when we say it like, I quite understand that you know it, but when you say it to me like you would say to the patient, take for instance, you said I would, you were saying I would, instead of could you do this for me, please? Can you do this? Just the way you will have interacted with the patient.
Yeah. Good comment, by the way. Yes, I accept it. So do it as instruction in the exam, not I would like to do. So you give the instruction to the patient just to be trained well how to do it in the exam. You're right. Absolutely right, Dr. Ayula. Continue.
Okay, all right. And also you picked the sign of heart failure in this patient. By the end of the presentation, you said there was no heart failure. Do you notice, did you notice that?
Yeah.
But the patient, there's no crepitation, no GVP, no
No,
beating.
no. She said there is crackle, right? I think.
Yes, and there's JVP and there was S3.
It's
Yeah.
okay.
Yeah,
Yeah,
I'm just pointing that to you. Is that what?
No, because I don't not listen إن في crepitation.
Okay, it's okay. I was just saying it just to let you know that it was there in the but altogether it was a good presentation. The summary was good. The way you answered the question too was quite good as well. It was quite good. And but yeah, that was just my observation really. It was a good presentation. Thank you.
ممكن بس أقول شغلة
Yeah, well
صغيرة.
done.
Thank you, Dr. Ayula. Yes, Dr. Hind, continue.
هلا لاحظت إن الكانديديت اللي عملت الكيس شو اسمها حتى نادية باسمها
دكتورة رشا.
رشا. طيب يا عسل. فأنت you said that I didn't hear crips. Most probably in the exam, raised JVPs sometimes by itself can be a sign of overload, if not associated with others. Second point, most of your patient will have been started on diuretics before you enter your exam. You will find the overload signs only obvious more in the lower limb, because this is the last thing to resolve after you give diuretics. While the diuretics will immediately have an effect على على pulmonary edema، بعدين على JVP، بعدين على البيدال edema. فusually حتى يعني they will be happy إنك أنت you did not say or judge about heart failure or overload from one sign. وبالعكس examiner is the one who will ask you, دكتورة رشا, why you said there is heart failure or overload and there is no crackles? And he is expecting you to say, because the patient must probably on diuretics, انت عملتي العكس. don't exclude الكريبس أو don't use الكريبس to exclude the heart failure. بالعكس عدم وجود الكريبس is a signs of, if it is يعني إذا في JVP والبيدال edema, most probably the patient on diuretics and you might face such a question in the exam. take care. وتاني second thing which can lead to raised JVP وبيدال edema without كريبس مين؟
tricuspid regurg.
tricuspid regurg. استنى
pulmonary hypertension.
عليك يا نور. انا هذا لانه البلمونري هايبرتنشن كمان حيعملك tricuspid regurg، صح؟ يعني حيكون functional tricuspid regurg، بس you are right it could be يعني it could be a valvular disorder. tricuspid isolated tricuspid regurg، بس يعني ما كانت ببالي. شكرا دكتور باسم، because usually it's not common in the exam، بس common pulmonary hypertension.
Yes.
Pulmonary hypertension with tricuspid regurg are the causes of JVP and pedal edema without CRIPS. إذا أنت now you are ready for any question from the examiner. خلاص you know. And that's why if you are in doubt about heart failure, use an overload, because overload will cover both of them. سواء heart failure, right side heart failure, or pulmonary hypertension with tricuspid regurg. تمام. بس if you are confident, you find your patient symptomatic, he seems to be in failure, you can say overload could be related to heart failure, right side heart failure. بالذات إذا حتعطي differential can explain this. take care of this in the cardio. يعني they play on this diuretic thing and pulmonary hypertension will tricuspid regurg. تمام.
Yeah, perfect. Thank you, Dr. Hind. I think Dr. Rasha and everyone, please, whenever you have collapsed pulse and bounding pulse, remember you might have suggestion of aortic regurg. Immediately start to pick up the finding of aortic regurg, the peripheral signs. It's very important. If you didn't mention all of them, or at least you can say, I would like to complete my examination looking for 1, 2, 3, 4. If you miss them, but it's important to pick up them whenever you have collapsed pulse or bounding pulse or wide pulse pressure or whatever the feature suggestive of aortic regurg. It's very important. From pulsating nail, as Dr. Rasha did at the end. By the way, you have time, Dr. Rasha, because you are saying the steps, but whenever you are doing the steps, you would consume, it would
Yes,
consume
take
your
time.
time.
Yes. Mhm.
Yeah. So try to train yourself. Whenever I have
Yes.
collapsed pulse, a significant collapsed pulse, and wide pulse pressure, so I suggest this patient might have aortic regurg. So I will try, even at the end, if you finish all steps and you are now remembering, I could find some of the peripheral signs of aortic regurg, do it at the end. If you don't have the time to do it, say it, I would like to do or to complete my examination by looking for the peripheral signs of aortic regurg. You can mention them 1, 2, 3, 4, better than missing them at all. Okay, so to say it or to say them better than missing them, but it would be much perfect if you do examining them, starting from the nail, the Mosse for the head nodding, the Corrigan for the carotid pulsation, and pistol shot for the femoral artery pulsation. Okay. Otherwise, Dr.
Yes.
Rasha, you do great, really. It's first time I think to do the short, but you did them
Yes.
perfect. Yes.
Yes, but I want to add a point.
Yeah, sure.
قولي انت
Okay. Okay. يعني الأورتيك ريجاج يعني I think this difficult cases because the collapsing pulse
Yes,
some
of course.
patients don't have a collapsing pulse. Regarding the diastolic murmur sometimes
Difficult.
يعني difficult to hard. فالأورتيك ريجاج sometimes patient يكون normal there's no any finding.
Yes, you're right.
Yes because some يعني do exam the first بالارب بورد كان الكيس aortic regurg البيشنت كان normal ولا there's no collapsing pulse no diastolic murmur there's no peripheral sign of aortic regurg فالاورtic regurg I think this case يعني اغلب يعني في الاكزام patient normal اصلا there's no collapsing pulse no peripheral sign no corrigan sign there's في البوك لكن في الريال ما فيش patient في يعني الحاجات هذينا يعني.
Be ready to have this patient and be ready to have the normal patient, particularly if you have collapsing pulse.
You mean don't buy يعني
Yes,
by
I agree
diagnosis
with you.
regarding collapsing pulse. Sometimes patients don't have collapsing pulse.
That's why, Dr. Rasha, I said even you can mention them verbally. I would like to complete my examination by looking for 1, 2, 3, 4, 5. Because you are saying I have suggestion of aortic regurg. So I have to do the examination for, even if you didn't do them, if you missed them, if there is no signs. But you can tell the examiner, I would like, or supposed to have these peripheral signs. Maybe it's controlled by diuretics, as Dr. Hen said, or maybe the patient treated or whatever. But you have to mention them.
Yes,
Aortic
you
regurg,
mentioned, yes.
yeah, exact. Yeah, aortic regurg, peripheral signs. And basis wise, they are asking about them. Okay.
كمان ممكن كلو يكونوا عاطينك البلاد بريشر or when you
yes
ask
the
about
blood
the
pressure
inside
الوايد pulse pressure هو الكلو
حيعطيكي very good clue و it is something يعني they cannot hide والaortic regurg cannot be without a wide pulse pressure. فإذا أنت كان عندك كيس مثل الكيس اللي أنت عم تحكي عنها و you missed to calculate the wide pulse pressure أو أخذتي or you took the blood pressure as a value أو as a step without paying attention to the values, it will be a big mistake. Second thing, and I was waiting you to say something other than the peripheral signs of aortic regurg. Peripheral sign of what else you are looking for? Which might be there in PACES exam and might guide you even if your pericardial examination is normal. The peripheral sign of the causes. أنا لو لقيت patient
yes like Marfan syndrome
أنا I was expecting you to offer الarm span to the
arm span yes
arachnodactyly thumb sign rest sign high
yes
arch
ankylosing spondylitis
already you
yes
open the mouth for the uvula مثلا ممكن تلاقي الانكيلوزنج question mark posture الانكيلوزنج psoriasis عندك الcollagen disorder. So if I want you to pick aortic regurg especially in PACES I can give you the blood pressure تمام
yes
I can give you a peripheral sign of any of those causes تمام. هلا لو انت اخذتيها normal case I think يعني this is very unfair لأنك you will think 100 times before you tag the patient لأنه كمان عندك مثلا ال MS يعني you might have MS ممكن AF ممكن من دون AF فال MS وال AR الاثنين diastolic murmurs و might be very faint و might not have a peripheral signs فيعني I will be يعني I would think 100 times before I tag the patient with any of them بس it is very wise if you have a normal patient but symptomatic from outside to start with these two لأنه diastolic murmur is always hidden and not clear like
yes like breathing sound yes
yes فيعني إذا أنا بدي يسألني الإكزامينر what do you think could explain the symptoms لأنه عادة الكوماند كمان بيكون في كلو أنا فايتة على patient يعني بس معلومة it's very important information there was cases of palpitation and the case was not valvular تمام و the whole discussion was about the causes non-cardiac causes of palpitation and I know this case اجت بيوكي وحتى اللي اجتها الكيس حكت لي عنه تمام. this was يعني the worst thing ever، لأنه أنت عندك palpitation is a valvular symptom can be يعني. بس at the end the examiner guide her إنه after she said normal examination he smiled and he told her okay tell me what are the causes of palpitation. بما إنه هي بcardiac station she was very clever. She told him cardiac and non-cardiac. He smiled again. He told her okay tell me the non-cardiac، لأنه هي كانت بكارديك ستيشن. فبدت بالديفرنشال بهالطريقة. بصراحة sometime when you handle your case in the context of the station they get really impressed. إنه أنت she was handling the palpitation in the context of cardiac examination. تمام. بس she was honest normal examination. She start with a good differential classification of differential. وimagine the case went investigation وmanagement to differential for non-cardiac causes of palpitation. تمام. لأنه cardiac causes you should have an abnormal cardiac examination. فلو افترضنا أنه أنت you face this situation you have a breathlessness ولا you have a fever you will find something. But you have a breathlessness for example or chest pain. Okay, so you will give the diastolic first, then the systolic if it is normal. But please tell that I couldn't appreciate anything. وأجمع جميع الإكزامينر إنه I would prefer that if you are about doubting something to say I couldn't appreciate rather than inventing. To appear as a non-skilled person who cannot pick a murmur is better than to appear as an unsafe person who pick false signs. تمام. So be careful of this. It happened many times that they bring normal cardiac cases. It was والله nice case يعني راجعنا صحيح. كنت بدي راجع معكم causes of aortic regurg. I think you mentioned some. You mentioned بس don't forget to please vasculitis. You didn't mention Takayasu, giant cell, large cell arteritis. تمام. You didn't mention infective causes مثل الميكوتيك aneurysm. يعني بعد الفنجل examination it's common to have a mycotic aneurysm بالaortic arch. syphilis. تمام. فالinfective causes وكمان
connective tissue already mentioned. Yeah.
connective tissue mentioned.
Connective tissue.
collagen
Yes.
disorder mentioned.
Collagen,
صح.
yes.
Hypertension, yes.
والسيرونيجاتيف.
Yes.
تمام.
Hypertension is most common, yes.
You mentioned the hypertension. That's why I didn't repeat. ما شاء الله you started with the hypertension. You missed بس الفاسكولايتس والسيرونيجاتيف والinfective causes. You mentioned الروماتيك fever أو الروماتويد. ولا ننسى إنه we need always يعني whenever we discuss the investigation aortic regurg is usually can be primary aortic regurg أو secondary to what?
Ischemia.
Coagulation.
To aortic root.
Yeah.
Aortic root, yes.
أو aortic root. you should put in your
Yes.
investigation what?
CT or MRI all aorta.
Aortogram.
aortogram.
اتفقنا. فالاكسرسايز tolerance test usually we don't mention it. خاص نحن فرحانين chest x-ray echo coronary angio يعني هي كليشيه usually we use it. بس in aortic regurg we can يعني appear professional by adding exercise tolerance test aortogram looking for the underlying cause could be vasculitic. you will sum it up. Vasculitic panel. Looking for any collagen disorder genetic testing, looking for seronegative by doing HLA B27 اللي هي very common هي العلامات الفارقة لهدول الcauses. تمام. The distinguishing points أو the key investigation for those causes. You can add them in the investigation. This how you appear like not stereotyped. خلاص يعني every time everyone gonna go inside he will say cardiac marker, ECG, chest x-ray, echo, coronary angio. So what you will add for your aortic regurg, you will add those extra investigation.
Yes, investigations underline cause, yes.
والaortogram والexercise tolerance test.
Yes.
تمام.
Yeah, thank you, Dr. Hind.
Yes.
Welcome.
Yes, thank you, Dr. Rasha and Dr. Ayula. Any suggestion or doubt? Any question? I think we covered both aortic valvular disease today, the stenosis and the regurg. it's good session, by the way. It's like summarize of aortic disease, either dilatation or regurg and stenosis.
About exercise tolerance test,
Yes.
it is paradoxical, I think, or I forgot about the result of in aortic regurg.
You
The
mean
specific result.
increase of heart rate and increase of blood pressure. But in this situation, it will be
ECG changes يعني if there is an ECG usually
yes, Dr. Hind.
they don't usually ask you specifically such a question where they ask you what is the specific changes in exercise tolerance test. Usually exercise tolerance test is to risk stratify a cardiac patient سواء كان ischemic أو valvular disease. تمام. Second thing, whatever we are looking for example in HOCM ولا in aortic regurg ولا in anything, ECG changes, blood pressure response, تمام,
Mhm.
whether increase or decrease, each of
Heart
these
rate.
results have a significant indication, والheart rate. وطبعا
Yes.
لو البيشنت become symptomatic على الاكسرسايز tolerance test لأنه الأنجينا إذا بدأ التشست بين ما بتستني ال ECG changes. If the
Mm.
angina started, you not wait the ECG changes. So either the angina or ECG changes, or blood pressure changes, will heart rate. Whether the patient is exceeding the heart rate expected for his age. كنا نقول age plus 220 والله نسياني كان لها معادلة.
I
المهم
think
this
they
is
will
what is
go deep to
important.
these details.
أبدا. Heart rate, blood pressure, ECG symptoms. This is
Yes,
irrespective
I
of
remember
the
that is
scenario.
specific in aortic stenosis more because it is making paradoxical reduction in systolic on exercise in aortic
يعني
stenosis.
صح كلامك ممكن هذا
Yes,
finding للأورتيك stenosis بس each cardiac patient they undergo exercise tolerance test for
Yes,
the
it is just to know how what is the measurement or the parameter we measure on it. Yes.
exercise tolerance test. He might ask you, especially if it is an important investigation.
But I think in aortic stenosis with caution exercise test, stress
Because
exercise
there is
test.
angina ischemia heart failure. It's more يعني more severe
Yes,
patient,
yes, more
more
with
risky.
caution, with caution, yes, risky.
مشان هيك لما بنقول الاكسرسايز tolerance test say if indicated and if safe لأنه
Yes.
أصلا الاكسرسايز tolerance test start to be unfavored بالنيو guideline. عن جد يعني عم بينسحب البساط من تحته most of because usually it is risky والبيشنت أصلا الاكسرسايز tolerance تبعه بيكون not very good they use الفارماكولوجيكال و they prefer now الفارماكولوجيكال echo عن الاكسرسايز أو الفارماكولوجيكال exercise
echo.
test.
But it is written really it is safe even in
yes,
severe
still
aortic
it is
stenosis
there.
and it
بس
still
يعني
they
when
depend
you
on it for prognosis of the aortic
حلو
stenosis.
بس إنه when you say it say with caution أو if indicated أو if it is safe. So the examiner بالذات بعض الإكزامينر مثلا مكتوب عندك من برا انجينا وفي ناس ما هم كارديولوجيست فواحد ما هو كارديولوجيست يشوف برا انجينا ويسمع جوا اكسرسايز توليرنس تيست بتلاقيها ترك كل الستيشن الحلوه اللي انت عملتيها ومسك بالاكسرسايز توليرنس تيست فتيك كير يعني كنت تقولي exercise tolerance test I agree it's still in the guideline but يعني one of the investigation which you should say done with caution أو if it is safe or indicated by the cardiologist تمام ف you are mentioning something but you are keeping it for the specialized people to decide about.
Yeah, good question. Thank you, Dr. Aisha. You can also add monitoring, and there is also criteria how when to
Yes,
abort
and
the
it's not
test.
wise if he has angina at rest or he has dyspnea already at rest. It is just for if you are like you need to get the symptoms. If he has no symptoms and you discover that he has aortic stenosis, you need to see how this aortic stenosis affecting by exercise tolerance. But I think if he has already symptoms of
Yeah, no
and
need to do it.
yes, no need. Yes.
So you can say it with caution, as Dr. Rasha mentioned. Okay, at least you should be aware about these tests, because we know all of them the usual answers, like chest X-ray, echo, ECG, as Dr. Hind mentioned. But there is sometimes specific test they want to hear from you. It would impress them, and it will not go too deep in the answer. So they will not ask you what about the heart rate, how much the increase, what the equation, because they are not cardiologists. And it's 4 minutes, by the way, so they cannot go to the much
هو معك حق.
detail.
Usually
Yeah.
they don't ask يعني especially in the
Yes.
cardio بالclinical stations nobody go deep لأنه it's very short. You will not be that speciality يعني the doctor who's
Yes.
examining you. بس إنه يعني it is as I said إنه بس just remember إنه it's not always
Yeah.
the same number of investigation. You mentioned them. Try to have some additional few test أو few investigation for each valvular disease يعني specific. مثلا مثل ال MS we usually investigate for AF so you add the coagulation profile,
Exactly.
bleeding
Yes.
assessment risk, Chad Vaz score, especially if you find AF you should not forget إنه AF investigation. فال MS مثلا is characteristic by these. وغير هيك كمان إنه ال MS characteristic by stroke workup لأنه sometimes it really precipitates since there is AF. You want to ask something about cardiovascular risk factor, lipid profile, تمام؟
Yes.
فيعني بالMS there are some added investigation.
Yes.
بالAR there are some added. بالaortic stenosis usually we add the cardiovascular risk factor لأنه it is usually with hypertension وdiabetes وelderly وdyslipidemia. تمام؟ فيعني for every valvular هيك try to pick some additional stuff.
Yes. Exactly.
Examine your mind in order not to say the stereotyped list mentioned by all the ولا ننسى إذا كان من برا أنجينا نضيف الكاردياك ماركرز، وإذا كان هارت فيلير نضيف البي ام بي، وإذا كان
Yes.
انفكتيف اندوكاردايتس نضيف الاي بي جي واللاكتيك اسيد. تمام. يعني هالاشياء هي ask about the allergy because you will start antibiotic. So whenever there is something from outside you have to think of it in your investigation.
Yes. As well as for the replaced valve, adding the INR for the clinic we mentioned earlier in the station.
If there is warfarin.
Yes, exactly. Okay. Any other question, Dr. Aisha? Anyone want to add question? Any doubts?
No, thank you. Thank you so
Okay.
much.
Okay. Thank you, everyone. Thank you, Dr. Rasha and Dr. Ayula specifically, and Dr. Hind, Dr. Aisha, everyone. See you tomorrow, inshallah, with long clinical consultation day. Good luck and good night. Assalamu alaikum wa rahmatullah.
Thank you.